17-year-old male patient has a left pelvic pain. You can go on.
I am presented with 17 years old. I am presented with pelvic radiograph of a skeletally immature patient. I can see permeative lesion at the inferior left inferior pubic ramus with the wide zone of transition, periosteal reaction, no pathological fracture, no soft tissue component, both hip shoe no dislocation, pelvic rim is unremarkable, permeative lesion in 17 years old. I will ask about if any constitutional symptoms.
He has fever.
Yes, constitutional symptoms.
Yes,
I will put
okay.
osteomyelitis first differential diagnosis. Other differential diagnosis, Ewing sarcoma. I will convey finding urgently to referring physician. Start IV antibiotic and refer patient to MRI to confirm diagnosis.
Okay.
MRI for the same patient. I can see a permeative lesion with large soft tissue component and invasion of the surrounding muscle. Uh, Destructive lesion with wide zone of transition and periosteal action, soft tissue component. The left humerus is unremarkable.
Yes.
Left femur is unremarkable. Right side is unremarkable. I wanted to see there is also soft tissue invade the pelvis. This
Yes.
is aggressive bony lesion with large soft tissue component. First, the differential diagnosis will be Ewing. I will convey finding to referring physician and request a biopsy in sarcoma center and refer to oncology MDT. Bone scan also is recommended. CT chest, abdomen, pelvis for staging. In my daily practice also, I want to see, can I see the post contrast?
This is, I think, no post contrast here. No post
The
contrast.
diffusion.
Why? Why you need diffusion, doctor? No diffusion. No diffusion. I think
Okay,
this may be diffusion. This is maybe diffusion.
this is high in
Okay.
diffusion. This is aggressive bony
Okay.
lesion. It's probably Ewing.
That's the first line of treatment in Ewing.
I will refer patient to oncology MDT and refer patient to tertiary sarcoma center for biopsy, bone scan and CT
Yeah,
chest,
yeah.
abdomen,
What
pelvis,
is what is the first
staging.
what is the first line of treatment in Ewing sarcoma?
Biopsy in sarcoma center.
Yeah, I'm
Then
talking about
start chemotherapy, radiotherapy.
why not surgical? See?
This is aggressive bony lesion with large soft tissue component.
So
So better to make chemo or radiotherapy to regress the size of the tumor than surgical excision.
what is the curative rate in responding to chemotherapy of Ewing sarcoma?
50%.
Okay, thank you so much, doctor. Take some home message.
Mm.
See? Here, your role in the exam is first of all, is tell the examiner either this aggressive or not. Okay. Next, you neglect this soft tissue. How could we know this soft tissue? Look at these gases. See why the gas came here and it shifted here, elevated. At least there are soft tissue here. Okay, look here, this fat plane. Look, we're here. Second,
Displaced.
uh, yeah, okay. Second point, this is okay, permeative, but looks like moss eating. What is moss eating? See, look, this is the lytic sclerotic with ill-defined and the wide zone of transition. This is the moss eating. This moss eating is regarding a name of one insect which eat, I think, our clothes or our stores. So cause the same appearance. So, يعني, okay, no problem. Not a big deal between either describing as permeative or not, but this is moss eating. Okay. Second, um, don't insist in one differential. You insist this is osteosarcoma. Okay. Second point, this is don't use the radiological, the X-ray terms here. Don't tell the examiner this is a permeative, this is wide zone of transition. No, no, no. This is related to X-ray. What we should here talking, we should describe what we see. This is a large soft tissue, aggressive tumor infiltrating the left hemipelvis or the left pubic, and describe what happened here with intrapelvic extension, displacing the bladder, what if extending into the adductor muscle, affecting the acetabulum with metastasis here. Look here. This is very important. Metastasis. Okay. So this is a large soft tissue mass infiltrating or center here, not a permeative lesion or a destructive. Okay. Uh, Next, when the examiner asks you about the treatment, you mean treatment, not next step. Okay. Thank you, doctor. You did very well. Next candidate.
Thank you,
Yes, sir.
doctor.
Can you hear me?
Yes. Candidate two.
Yes, sir. I'm here.
Yes. Welcome, doctor.
Okay, so I have been provided with the
One
radiograph
second.
left.
1 second. See, if the examiner didn't give you the history and you start like this, he will not be happy
Okay,
because
okay, okay,
history may change totally your answer. 10-year-old female
okay,
patient playing basket and fell pain.
okay.
Go on.
Okay, I have been provided with radiograph pelvis on the left side, AP view, and I can see that there is a lucent area along the medial aspect of the femoral epiphysis with a sclerotic line along the medial femoral head. I can also see that there is minimal irregularity at the trochanteric region on the greater trochanter. So, uh, given the history of rest of the pelvic bones appear normal, the left SI joint appears normal. So, I am thinking of any uh, fracture any avulsion fracture at the trochanteric region and also at the femoral head. There is no definite soft tissue component or periosteal reaction. There is no definite periosteal reaction in the femur. So I would further want lateral or a lateral view or the rest of the views for the evaluation. Okay, I have been provided with the axial view of the femoral head, and I can see that the femoral epiphysis appears normal. Um, there is no definite evidence of slipped capital femoral epiphysis. There is the surrounding soft tissues. There's minimal soft tissue swelling in the surrounding region around the hip joint. Rest of the proximal femoral shaft appears normal. The pelvic, the ilium and ischium also appears normal. So I would ask for uh, history of any fever or any tenderness at the hip joint. I
Sir,
am thinking of any joint effusion.
where is exactly the area of concern according to you?
Uh, 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 I I saw that there was minimal irregularity at the greater trochanteric region. There was a lucency which appears projectional given the axial view. So main pathology was at the
What else?
trochanteric region.
No. What
Okay,
else?
I can also see that there is minimal irregularity in the femoral neck region. There is minimal lucency and
Request
minimal
control.
irregularity at the femoral neck.
Request request
Sure.
control, please.
Okay, sure. I have requested. I have
Show
requested
me
control.
exactly the area of concern.
Okay, I can see that there is a sclerotic line in the femoral neck region right here.
Show me by the mouse. Use the mouse.
So can you see?
Yes.
So can you see my mouse now? So I can see
Mhm.
that there is sclerotic line along this femoral neck region right
Okay,
here. So I am
leave the
thinking
mouse.
that
Leave the mouse
okay,
1 second. 1 second.
okay, sure,
Look
sure,
at
sure.
this. What happened? Where is
So
exactly?
I can see that there is persistent sclerotic line right here in the femoral region. This may represent
Okay.
any certain femoral neck fracture.
Okay. What will you do next?
Uh, I want to immobilize the patient. I would also want to perform CT for further evaluation of this femoral neck region.
Which examination do you want?
I want to perform CT of the left upper extremity to rule out any fracture at this region.
Do you think ACT is the best choice for this age group?
We performed ultrasound to rule out any joint effusion in this age group first, and then we proceed towards the
But
CT.
you have, Dr. Sisi, you are talking about bone sclerosis. How could the
Okay.
ultrasound be the next step? This is not
We
fun.
can also perform MRI to rule out, but there is a long wait for the MRI, so that's why I asked for CT first.
No. In pediatric age group, MRI is better to protect them from the radiation. Go on.
Okay, so I can see that there is a mild joint diffusion in the left hip joint, and there is a significant edema in the femoral neck region. I want to look at the T1 to rule out any fracture line.
The T1.
So in the coronal T1 section, I can see that there is uh, a hypointense area along the medial aspect of this, and there is significant joint diffusion. Which is concerning for a fracture at this area given the history of trauma.
Okay. Look here, please. Look here.
Okay, so I can see that there is a very small hyper intense area with significant surrounding sclerosis. I have also a concern of osteoid osteoma at this region with surrounding edema and joint effusion. So we can proceed with limited CT to exactly confirm this, or we can also perform nuclear scan to confirm this. Okay, so I can see that there's a very cortical, very lucent area with surrounding sclerosis, which is highly concerning for osteoid osteoma. So I would inform the primary physician about these findings, and I would ask for radiofrequency ablation of this lesion uh, for further management.
What is you mentioned that you will do bone scan. What will you
Uh,
see in the
in
bone
bone
scan?
In the bone scan, it shows a double line sign with central increased activity and surrounding reduced activity, which is highly sensitive for osteoid. The central lucent focus shows increased activity on the nuclear scan.
What is the difference between osteoblastoma and osteoma?
The difference is about the size. Osteoblastoma is less than 1.5 centimeters, and osteoblastoma is more than 1.5 centimeter. Osteoblastoma is more in the central bones, like in the spine, posterior elements, and osteoblastoma is more in the peripheries.
Okay. In bone scan, again, what is the name of the sign that will you see?
I guess
This
it
is
was
not a
donut
double,
sign.
not a double line sign.
Uh,
What will you see?
I
describe.
cannot remember the exact. The central focus shows high uptake, and the surrounding focus appears the low uptake. I guess it was donut sign.
Okay. It is either double density sign or hotter
Okay.
within hot signs. Anyway,
Okay.
if you
Okay.
told the examiner the significance, he will be happy because we have a lot of hundreds of signs within the literature. Thank you, doctor, so much. But take care, my colleague. What happened here? This is the abnormality is here. There are thickening here. Second, what happened? You, I give you this one. You are worried about this greater trochanter, despite you know that it may be or projection. Why? Because you put in your mind the history of playing basketball. But the examiner make a trip here or make a trick here. The case answer is another pathway. So take care, my colleague. Take care from this. Okay, what happened here? Sclerosis here at least. Okay, and the by comparison, this area is more sclerotic than the right side. Okay, so enumerate the different causes of bone sclerosis, focal bone sclerosis, like okay, stress fracture. Okay, but stress fracture should more horizontal. Second, osteoid osteoma. Okay, it's very important. Third, Ewing sarcoma. Fifth, whatever infiltrating tumor. Okay, but first of all, mention, give me some. Okay, next point here, MRI. Please, my colleagues, when the examiner give you sequence, smash and squeeze all the possible. Why? Because the answer is in the first one. Most of us will miss it, and then we'll talk about this effusion and edema, and then we'll ask for Cronin, other Cronin, T1, and the answer is here. And it is not good for you to ask again for a sequence that you finished. I think you will not be courage enough to ask it again. Look here, this is the intracortical uh, lesion, this one. So you ask it for CT. In pediatric or children, the only allowed to do CT indication if you are in doubt about osteodyostoma. Okay? Osteodyostoma have lucent nidus with this is central calcification. Okay? Plus surrounded by sclerotic reaction. Please, my colleagues, this is three different entity. Osteodyostoma generally is a lucent, non-mineralized bone with central calcification with peripheral sclerosis. Okay. The treatment including prostaglandins, antiprostaglandins, RF, and all the tables that we are know well. Take care, my colleague. This case that has two tricks. Number one, the age group. Number two, the complaint or the history. The history was misleading too much. Other differential diagnosis, at least you can tell the examiner, doctor, at least if you didn't see it from here. You can't see. Doctor, there are effusion and the edema. So my differential, number one, transient sinusitis. Number two, septic. But here you need contrast to rule out any abscess formation. Number three, I should search for osteoid osteoma. Thank you, doctor, so much. Next candidate.
Hello. Hello.
Yes, hello.
Assalamualaikum.
Salam. Hi, doctor. Are you ready?
Hello. Yes, sir, I'm ready.
Yes. This is 12-year-old female with lower limb paresthesia.
I've been provided with the X-ray of the abdomen and pelvis of a young child. There appears to be a defect in the posterior elements of the sacral vertebrae, uh, uh, most likely suggesting uh, spina bifida or meningocele posteriorly. Rest of the visualized bones appear normal. No fracture seen, no other any soft tissue abnormality seen. So, given these findings on this X-ray, the most likely diagnosis is the neural tube defect, most likely meningocele or spina bifida. So, I would advise MRI of lumbosacral spine of this patient and referral to the pediatric. So I've been provided with the T2 weighted images of the lumbar spine. The cord is extending inferiorly up till the sacrum, suggesting tethering of the cord with the high signal in the cord, suggestive of syrinx, most likely. There is no defect noted on these images in the posterior elements. So, however, on the axial
Are you sure, doctor?
views,
Doctor, are you
sorry?
sure there are no defects?
No,
Are
no,
you sure?
there is defect in the posterior elements, which I can see on these axial images, that there is a defect in the posterior elements of is more marked toward the right side. Uh, so there is defect in the posterior elements, suggesting of a myelomeningocele.
Okay. What
So
else?
mm, and plus with the tethering of the cord, is there any T1 weighted images available?
No, no, all T2. So what's your
All
final
T2.
diagnosis, doctor?
My diagnosis is that there is myelomeningocele involving with the tethering of the cord and most likely caudal regression syndrome. So I would advise further referral to the pediatric department for further evaluation with the pediatric neurology and pediatric surgery department.
Excellent, doctor. Thank you so much. Very well, really. This case of multiple finding, syndromic finding, what happened here? What happened? I think the examiner will not give you a good history. He may told you a routine checkup. Why? Because if I told you the actual history, look, you will answer. If the patient has neurogenic bladder, paresthesia, so immediately you will go to the spine and rule out spina bifida and the related spinal vertebral column anomalies. What happened here? No sick or sacrum, just S1 only, and even spina bifida here. And if you look here, even the wings of the blades of both sacral side are very small. Okay. Besides that, you feel there are some asymmetry between both pelvis sides. Okay, so we are dealing with caudal agenesis syndrome or sacral agenesis syndrome. So he gives you or you are request MRI. This is tethered cord. Doctor, what the meaning of tethered cord? I think a case like this, the examiner must ask you in some finding. What do you mean by tethered cord?
So when the cord is extending below the normal level and is tethered to the lower, like tethered to the sacrum or the bone.
What is the normal
Uh,
level in this age group?
in this age group, usually it is L2, L3 level in this age group, but
Okay,
on this one, it is extending up to the almost S1 level.
okay. And besides that, there are syringomyelia or central dilatation. Okay. Uh, in addition, there are defect here. Okay. Even we saw it in uh, in the X-ray. Okay. Also, we should tell the examiner, doctor, I want rest of the exam to rule out any vertebral anomaly like butterfly vertebrae or hemivertebrae or what else. Okay, my colleagues.
Thank you.
There are one case like this. The examiner bring it, and it was not static. It was DICOM, multiple series. And when you scrolling, you will see bilateral hydronephrosis by the aorta. Okay, so you should tell the examiner, doctor, this patient has bilateral hydronephrosis. He may have an neurogenic bladder. I wanted to do abdominal ultrasound. Okay, doctor. Even if you didn't see, you should also tell the doctor, the examiner, that you want to check urinary system because it is very common. Even these children, one of the first presentation for them, urinary symptoms, incontinence, what else? Thank you so much, doctor. There are, by the way, my colleagues, two types of caudal regression. Two types, type 1 and type 2. Both of them related to the level of the cord. Where is the cord? Look here. See, my colleague, when there are no tesseract cord, conus medullaris at the normal level, this is means group 1. When it is tesseract cord, this is group 2. Okay? Just small, simple piece of information. Thank you so much, doctor. Next candidate.
Yes, sir.
Hello.
Thank you so much.
What's the name? This young child, 5-year-old female patient, presented with right ear pain and progressive hearing loss. Okay, go on.
So can I request control? So I have a question. Okay. I am provided with the CT scan non-contrast images of a 5-year-old who presented with right earache and progressive hearing loss and with history of prematurity. I would like to scroll from the start, and then the first obvious abnormality I could appreciate was on the right. I would like to see it again. Yes. So this was the abnormality. It's I'm trying to look its epicenter. I think it's within the right petrous bone with suggestion of extension in the right middle ear cavity, which I would later confirm on the bone window images. I could appreciate some fat fluid level within this mass, and I could also appreciate that there are some calcific foci, and there is peripheral rim calcification, and there is internal calcification within it as well. So I think it's extending within the middle ear cavity. And so can I see it on the bone window, as I think it's involving the bone, and it's yeah. Now I'm provided with the bone window. I just want to scroll the start first. Okay, I could appreciate, yeah, the abnormality is centered within the petrous apex with calcification, fat component, and I could also appreciate that there is opacification of the right mastoid hair cells. It is extending inferiorly into the jugular foramina, which appear widened. So, considering the imaging appearances and the presence of fat and calcifications, I'm thinking of some congenital lesion. The lesion is, sir, I am thinking in lines of any teratoma in this region, although I haven't seen any in my routine life. There is expansion of the neural foramina. So the schwannomas and neurofibromas, they do not have a typical appearance like that. Sir, can I have a post-contrast sequence or further MR to confirm my findings? Okay, sir, just give me a second. I think there is the right mandible is also expanded. I would like to see that also. Yes, the right hemimandible is also expanded. So just a second. Yes, the right petrous apex is also expanded and it appeared thickened. Other abnormality of any osteomyelitis can be there, but there is no bone destruction, so it appears less likely. And so can I want to evaluate it further with an MR to see any diffusion restriction and any to further confirm it.
Oh, look again, please. If you want MRI, okay, I will give you. I think we have.
Okay, sir.
Leave it alone. Please. If you want to say. This is MRI.
Sir, I think, sir, I am provided with axial T1 post-contrast images. I would like to scroll it. It is showing internal, I think it is showing some, it's not moving. Yes, now it's moving. Okay. I am provided with axial T1 post-contrast images, and I could appreciate that it is showing some post-contrast enhancement. There is peripheral post-contrast enhancement. There is some solid enhancing component as well. It's extending into the middle ear cavity. Sir, because of the fat level and this peripheral enhancement, I am thinking of fat-containing lesions. So, a malignant teratoma, I'm thinking in lines of that. Other differentials would be of the cholesteatomas are T1 bright and they do not have this level. It doesn't. Sir, can I show? Can you show me the diffusion restriction images as well?
What do you want?
Sir, diffusion restriction images.
Okay, the diffusion.
Sir, I think there's a small focus of diffusion restriction in it as well. So I can't think of anything else. I think it's because of the fat fluid level. I'm thinking in the lines of teratoma. However, there was expansion of the neural foramina, though, so the schwannomas and nerve sheeting would likely do that mostly, but they do not have this fat fluid levels in them, and there's a solid enhancing component.
So what's your final diagnosis?
Sir, I'm thinking in lines of teratoma and a malignant dermoid.
Could you have a look
Malignant
again?
teratoma.
Okay, so you have a look again at these CTs, bone window,
Sure,
one
sir.
by one. One by
Okay,
one.
sir. Sir, there are multiple lesions. I could appreciate in the base
Yes.
of the inferior occipital bone as well. So, sir, I would like to change my differentials. I think this could be a case of, as this is a child, so this could be a case of eosinophilic granuloma. It could be neuroblastoma mets, or it could be even sarcoma with bony mets, because these three mets are most common, and I would like to place even eosinophilic granuloma or LCH on the top. And that might be some soft tissue component, but I'm still confused about the fat level.
Okay. Anyway, at least it is a polystotic lesion. Okay, my colleagues, a polystotic. If we missed that there are multiple bony lesions, it will be a big mistake. If you told the examiner this is a lytic lesion, maybe Langerhans cell histiocytoma, maybe fibrous disability, okay, يعني okay, but better to reach a proper diagnosis. Why? Sorry, I'm confused because I prepare one fibrous dysplasia case, I think, today morning, but
No
I'm
problem, sir.
confused.
It's okay.
Frankly, really, there are no ground glass here. No. Okay, my colleague, here in the spine, Look here. See? Reduced height, at least in those. And we are searching for vertebra plana. Okay? So it was a case of Langerhans cell histiocytosis, polystotic lesions. Okay, versus metastasis. It is acceptable. Thank you, doctor, so much. Let's go for our next candidate.
Assalamu alaikum, sir.
Wassalam. 1 second. Doctor, this is 40-year-old male patient presented with progressive weakness during walking. Go on.
Sir, I've been presented with the
Can you wait 1
Sir, I-
second to answer these questions, maybe related to the last case? What happened? Okay. Most of the chat box. Dr. Amiga, which X-ray do you want to see again? You ask for X-ray again. Most of the chat box asked about the last case. I'm sorry again. It was a case of Langerhans cell histiocytosis.
Caudal
Okay.
regression syndrome, Dr. Rami.
I will send to you. Don't worry. Okay. According to the last
Sir,
case, it was.
Yes, sir.
Yes. Tell me.
Sir, I will request control.
Yes, yes. According to last case, again, multiple lytic lesions. Okay. It was Langerhans cell histiocytosis. May be confused with the fibrous dysplasia, but frankly, there are no obvious ground glass appearance. I think we should search, but if we have sagittal or coronal for bevel design, appearance of both skull table, but unfortunately, I think we has only axial skull bone win. Go on, doctor. This is a 40-year-old patient who have progressive weakness.
Sir, I've been presented with the sagittal cervical spine T2 weighted images, and the first abnormality that I note is actually the narrowing of the foramen magnum with the backward orientation of the first cervical spine, with the kinking with that is abutting the cervical canal with the subsequent high signal within the cervicomedullary junction, causing the cervical myelopathy. And I can also see that there is an increase in the distance between the dens as well as the first cervical vertebrae that appears to be more than 3 millimeter, which is which is actually the normal limit for the adult patients. Apart from that, I can see multiple cervical disc osteophyte complex which are abutting the thecal sac and subsequently upon the cervical cord as well. And I can see that there is a narrowing of the cervical canal at these levels. If we go further down, there is the exaggeration of the cervical curve is also noted. As we go down, the spinal canal diameter appears normal in the upper thoracic level. So the first, I would like to see these images on axial scan as well, but I believe that there is some sort of there's some sort of subluxation at the base of the skull. With the atlantoaxial subluxation with increase in the distance. I would like to know the history of any inflammatory arthropathy in this case to further delineate because this can happen in rheumatoid arthritis as well. And
Rheumatoid
but
arthritis.
however, it is this is that is associated with the penis formation. So the subluxation. Sir, can I see the axial to further see the... Yes, sir. In the axial sections, I can... So, so, the demonstration of the narrowing is noted with cervical myelopathy. Sir, can I have a look on axial T1, sagittal T1? Sorry. So, sir, I believe that this is atlantoaxial subluxation with increase in the distance between the first arch dens
Okay,
and the
okay. What
first
about
arch.
this one? What about this? What is?
Yes, sir, this is actually the first cervical vertebrae, sir.
What is this? If this first, what is this?
Sir, there is definitely increase in the distance between the first cervical arch and also the second the vertebrae, and and there is no evidence of any penis formation. So this is a case of atlantoaxial subluxation, and the arch has moved anteriorly, and the distance is increased from 3 centimeter. And
Okay,
this
but you didn't
atlantoaxial
tell
subluxation has
you.
caused compression upon the cord.
Okay, okay. You didn't tell me about this one.
Sir, this could be this is actually, sir, this is the os odonteo. This is the first arch, and this is the os of the second.
What? Excellent.
So
So, what's it?
so I think,
What's
sir,
your?
there is a subluxation at this
Okay.
level between the os and its body from this at the level. So, sir, and there is some lower signal soft tissue density that is occupying the distance in between them. So, sir, yeah, as there is no history of trauma and there is backward subluxation of the C2 and the C3 vertebrae that is causing the cervical myelopathy. As there is no history of trauma, so it can be related to some inflammation or some inflammatory arthropathy or this penis formation could be, sir, the things which are common here are either rheumatoid or it can be associated with CPPD or, sir, there is
But look
sometimes there
here.
is
Look, you
associated.
are right. See, by the way, you are right. But look here. This bone has cortex and medulla. So
Yes, sir.
what may be what might be? Give me any suggestion.
Sir, it doesn't look like a fracture of os, but it does appear that this is a dislocation superiorly of the os odontium, or it
Okay.
can be um, uh, um,
Unfused.
unfused. Okay.
Unfused. Okay. This is what I
Yes,
want.
sir.
Thank you
Yes,
so
sir.
much.
Unfused. Thank you, sir.
What is the management? What is the management
Um,
according to this
Sir, it
side?
is an urgent referral to the surgery because it is causing the compression upon the foramen magnum and also the myelopathy of the cord. So it should be immediately referred to the neurosurgery for the management, most probably surgical, to relieve the compression upon the cord.
Thank you, doctor, so much. It was a case of atlantoaxial subluxation. And see, this is ostodontoid that not fused, unfused. Okay.
Yes.
It maybe looks like you said, really you enumerate all possible differential. It may be a deposition of mineral like CBBD, but it has a cortex and medulla. Okay, but it may be a penis, but the penis must cause some erosions here and here, aggressive inflammation here. Okay, the last look here. If you look here, this one, I think this is look here. Unfused os, unfused, not a fracture because it has a cortex. Okay, thank you so much,
Yes.
my
Thank
colleague. It was
you, sir.
ostodontoium with atlantoaxial subluxation. It is very important because it is, leave the mouse, please. Is
Yes,
markedly
sir.
compressed craniocervical junction. Okay, doc, and causing cord malacia. What is the difference of cord malacia and cord edema? So you
And
what's the
cord, sir, what?
difference?
Cord Malaysia and cord?
Edema.
Sir, cord malacia is basically formation of cystic, like it is almost like encephalomalacia. And edema will be subtle high signal, but there will not be shrinkage of the cord, and it will be high signal, and there will be central canal,
So you
like it's an
mean
atrophy of the cord.
yeah, you mean coordination must have some atrophy.
Atrophy,
Thank you so
yes.
much. Yeah. Next candidate. Next candidate. Hello? Hello?
If not present, candidate 7, please proceed.
Assalamu alaikum.
Wassalam. This is 70-year-old female patient has left hip pain. Go on.
Okay, I have been presented with the X-ray pelvis of a 70-year-old patient who presented with left hip pain. I can appreciate that there is sclerosis of the left femoral neck region, as well as the intertrochanteric area. There is sclerosis as well as reduced diameter of the left femoral neck. There is some mild adjacent soft tissue swelling noted. I cannot appreciate any fracture. There are mild degenerative changes in bilateral hip joints. There is no evidence of periosteal reaction. And
Yes. Hello? Hello?
I'm sorry, my connection became unstable. I'm
No
sorry.
problem.
Yes. So there's no obvious as compared to the right side, there is mild expansion noted at the intertrochanteric region of left femur. This patient presented with hip pain. Okay, can I see the orthogonal view?
Okay.
Okay, on the orthogonal view, there is again significant sclerosis of the femoral neck, and I can see some subtle radiolucent line also noted at the neck region. I would further advise the MRI of the patient. The differential diagnosis here is Paget's, or
Would you think budget will decrease
no,
the
actually there
size
is
or increase the
no.
size?
It is actually the size is actually decreased, but there is sclerosis.
Mm-hmm.
Other
So,
possibility can be. Is there any history of previous trauma?
no trauma.
Okay.
Mm-hmm. So,
Okay. Um, Sir, I will further see it on the MRI because there is actually the bony scalloping that is causing the narrowing of the femoral neck. So I would like to see the soft tissues on the MRI because I can see that there the soft tissues are bulky, and the fat planes are blurred.
okay, but give me any suggestion, any
Any
differential diagnosis.
so soft tissue sarcoma.
Soft tissue sarcoma. Look again,
Yes.
please. Why soft tissue sarcoma? What is the name of this sign?
Name of sign?
Mm. This appearance has very specific name.
Shepherd crook?
No?
No.
What else?
Pistol grip deformity. I'm not.
Okay, what do you want?
Further MRI.
This is MRI. Sorry, MRI. This is MRI.
Okay, I've been provided with the MRI T2 weighted images in which I can appreciate that there is significant uh, uh, soft tissue. There are prominent soft tissue masses that are seen on the left side surrounding the left hip joint. These are seen on the medial as well as on the lateral aspect, and also there is extension seen within the, yes. These are fat set images, multiple lobulated hyperintense soft tissue lesions are seen involving both the medial and lateral aspect of the left femur. There are mild hyperintense signals noted within the greater trochanter and proximal shaft of the femur within the marrow. These hyperintense signals are also noted involving the left femoroacetabular joint. No significant joint effusion seen.
What's your differential diagnosis?
Okay.
Request
So,
control is
yeah, okay. Yes, I have requested.
have a good luck and then tell me your
Yes,
differential.
yes,
Please.
yes. These are lobulated hyperintense lesions that appear to be insinuating in between the planes, and um, is there any possibility of nerve sheath related tumors? Mm. So can I see the susceptibility weighted image?
Susceptibility, okay. There are gradients. Go
Yeah,
on.
gradient. Yes, gradient.
Mm.
Okay, on the gradient echo. Okay, no areas of signal loss noted. There is significant bony remodeling. Okay.
Oh, what's your final diagnosis?
Sir, final diagnosis. So these are not giving the bone signals to suggest any synovial osteochondromatosis or
Mm-hmm.
definitely soft tissue masses, but
Okay. Look here.
okay.
What do you think? What is this?
This
Hmm.
is
What is this?
yes, these are low density areas.
Hmm.
So this is
So what's
synovial
your...
osteochondromatosis.
Yes. Look here. Despite it in CT, see, look. Hmm. What's your final diagnosis?
So there are no bony densities noted on the CT.
What's your final diagnosis?
Um, no bony, no joint effusion. If we consider the PVNS, there is no joint effusion noted as well, and there was no blooming artifact seen.
Okay, what is the name of this sign?
So this appears to be like an apple core, but
Yes, apple core appearance in X-ray is very pathognomonic for synovial abnormality, proliferation, at least.
right, right.
Not aggressive or malignant. Why? Because this concerning a chronic process. This is first most important thing. Second, MRI here. Okay, look at the MRI. T2. Innumerable loose bodies. look, 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 innumerable. Okay, so it is osteochondromatosis, synovial osteochondromatosis. In stair here, it is very confusing in stair because our ingredient even looks like synovial hyperproliferation. So you are thinking in synovial mass without those bodies, really. Uh, so when you ask in this is a gradient, no any signal loss. So this is not pigmented villonodular synovitis. Why is this not a synovial sarcoma? Give me two reasons.
This doesn't appear to be aggressive. It is not causing involvement of the bone. It is just causing scalloping of the bony margins. And
Okay.
further, I should have asked for the post-contrast images to see the contrast enhancement.
Well, okay, but see, synovial sarcoma يعني almost extra article.
Right,
Extra
extra.
article. But see, this is from the joint itself. Thank you so much, doctor.
Thank you.
So take care, my colleagues, from this sign again was eating core apple appearance of the of the femur neck. It is related to a synovial hyperproliferation. Okay, thank you so much. Next candidate. Next candidate.
Yes, sir. Assalamu alaikum.
Somebody, can you show the contrast study? I think no contrast here. Contrast in the MRI. Yes, there are contrast. Is the contrast? Look at the contrast, doctor. Please, our candidates who request the contrast, can you open the mic? This is the contrast. Hello? Anyway, this is the contrast. The contrast show marginal enhancement of the synovium itself, and what inside is non-enhancing, either fluid and loose bodies. So it is not synovial sarcoma. Okay. Thank you so much. Doctor, this patient has headache and the left eye pain. 85-year-old female patient presented with decreased vision in the left eye. Look here.
Okay. So I've been presented with axial flare. Okay, this is axial T2 weighted images of the brain. So I can see multiple hyperintense
Request control,
foci.
please. Request
Okay.
control.
Okay.
Go on. One
Okay.
second.
Okay, I'm scrolling now. So I can see multiple hyperintense foci in the bilateral basal ganglia, and I'm going looking through the image to see if there is any other finding. Okay. So yeah, there is no significant hydrocephalus. There is no other focal lesion, just some small hyperintense signals. Can I see the other images, the axial flare? Okay. So on the axial flare images, I'm going through the image. Again, I can see the tiny low signal foci here in the bilateral periventricular region. There is no other signal. So can I look at the axial MRA? Yeah, so I've been presented with the axial MRA images, and I can see that there are multiple vessels, tiny vessels seen in the bilateral sylvian fissures. And this is the last cut. Okay. No, it's not going up. Okay. So, yes, there are multiple tiny vessels seen in the bilateral sylvian fissures, and there are no flow void or filling defect seen. So, sir, I had suspicion that this is multiple tiny vessels. So I'm looking for any defect. The internal carotids appear normal. Sir, I had suspicion that this is moya disease. I could not see any enlarged, any other vascular abnormality. Can I look at the MIP image?
Look at this again, please.
Okay. Okay, I can see that there is a filling defect here in the left vertebral artery. And yes. And then the basilar artery appears normal, and there is no other flow void seen. So this could be a thrombus in the left vertebral artery, but I do not see any area of altered signal in the parenchyma.
One second.
Okay. So can we change the image?
What do you want, doctor?
So can I see the MIP image, the 3D image?
This one
Yes,
or this one?
this is better, I think. So, okay, so I'm looking at the,
Look here. Let me help you.
yes.
Look.
So, yeah.
What happened?
Sir, I'm looking at the image to see if there is any defect. I do not see the sir, there are multiple collateral formation on both sides of the brain. So,
Click the mouse. 1 second. I will help you.
okay.
What happened here? Look. What happened?
Sir, can I please scroll? Okay. I'm looking for any arterial defect. I don't see the right
1
sided
second.
and okay, this
1
is
second.
visible. Yes, sir.
Tell me what happened here.
Sir, the left ophthalmic vein
Yes.
appears opacified, yeah,
So,
on the arterial phase, yes. So this looks like a case of cavernous fistula with the early opacification of the left superior ophthalmic vein.
okay. So, uh, take care, take care from this case again. Okay, because the examiner will not make this too much help, especially from, I think, flare studies. Flare, you can pick up it. Look here. If you go slice by slice, you can get it, I think. Okay. At least, really it is difficult here. At least when you see MRA
Yes, sir.
like this, one of your review area to check up post orbit. Okay.
Yes, sir.
Go one by one. The most confusing point here, the superior recti muscle, this one, I think,
Yes, sir.
confusing us with this vein, but the vein is curvilinear. If you look,
Yes, sir.
curvilinear, and
Mm-hmm.
compare with the contralateral side, this is the superior rectus muscle. Okay.
Yes, sir.
Uh, what what is the causes of carotid-cavernous fistula?
So these could be post-traumatic, uh, and it could be as a result of any uh, um, mass lesion.
What else?
So, so trauma, I think trauma is the most common
Okay, what
cause.
else?
Mm,
Mm-hmm. Idiopathic, trauma, infection. Okay.
yes, so trauma, I said. Yeah,
Yeah,
infection,
idiopathic, infection, all of this.
idiopathic.
Okay.
Okay,
So,
okay, sir.
my colleagues, what happened? The artery pathologically connected with the cavernous veins. So, the
Okay,
intra-cavernous pressure raised. Okay. So it causes a reflux here, reflux in the superior ophthalmic vein. Thank you, doctor, so much.
thank you, sir.
Take care, my colleague. When the examiner show you any one of this angio, take care not only of the main arteries. I will tell you many of the text and the confusing point. Number one, he may give you like one flare, and the abnormality is here. There are dissection or occlusion of one of the carotid vessels. Take care. Or either the patient has aneurysmal dilatation, either in Sylvian fissure related to MCA, or in the circulus of Willis, or here in the interhemispheric fissure related to ACA. This is another point. Number three, take care of the vertebral arteries. Okay, this is the vessels generally, especially the carotid, one of the very important review areas. Also, the orbits and skull base and both internal auditory meatus. Okay, this is very important. Look here, signal void. Very important to check this signal void. Here in the MRA, you will see it piece by piece, and finally it is normal. From down, up, it is normal. And the patient has abnormality in the left eye. So concentrate in the left eye one by one, and your eye in both eye. And concentrate your vision in both eye. At least you will find something here, not like the contralateral side. So, and it is curvilinear. So, it is carotocavernous fistula. Dr. Amiga, are you ready?
Yes, yes. Good evening.
Good evening. Uh, See this
Okay.
patient. By the way,
Okay.
it is difficult case. Okay,
Okay.
55-year-old male patient presented with abdominal distension.
Okay, so I'm provided the T2-weighted MRI images of this 55 years old male who is presented with abdominal distension. I would take a moment to go through the entire stack of images. Okay, the small bubble loops are placed in the center suggestive of ascites. Uh, there is also bilateral pleural effusion. I think there is some evidence of omental thickening noted. And okay, can you please go down? I think there is no significant dilatation of the small bowel loops seen. The ascitic fluid is showing high signal intensities with some areas of high. I am suspecting that is there some scalloping of the liver surface seen? I'm suspicious of some scalloping of the liver surface.
So,
Um, and so all these findings I'm suspicious of, and there is also omental thickening, scalloping of liver surface. I'm suspicious of some Pseudomyxoma peritonei.
okay,
I would
look
like to
at this
correlate
one.
this. Okay, so these are post-contrast T1 weighted images. And this again redemonstrates the presence of fluid in the abdominal cavity. And okay, I would like to see the appendix, area of appendix, as to see some any intraluminal mass lesion in the area of appendix. Um,
I think this is available. Hmm.
okay.
So give me final diagnosis.
So in this patient with scalloping of the liver and the heterogeneous heterogeneously appearing ascitic fluid, I'm suspicious of Pseudomyxoma peritonei, and I would like to rule out, if it is a female patient, I would like to rule out some ovarian neoplasm, or in a male patient, I would like to rule out any mucinous adenocarcinoma of the ovary, of the appendix as
Okay.
a cause, and I would like to correlate this with the
CA level. Thank you, Dr. Amida, so much.
thank you.
Take care, my colleague, of this is a pseudomyxoma peritonei. Why? Extensive high density or high signal ascites, but in the T2, not completely. This is the CSF-like or fluid. But here, you feel like it is not the same signal. It is less than this one. So you feel that there are some protein here. Look at the liver. The key to pick up the pseudomyxema peritonei is the border of the liver. Look, scalloping. So if he is a male, you should search about appendicular, adenocarcinoma. Okay? If she is a female, okay, you should rule out any mucinous adenocarcinoma of the ovaries. In post contrast, the only mentioned thing here, there are some enhancement in the right colon, ascending colon. This is the only thing mentioned. Anyway, this case I presented to show you the shape of pseudomyxoma peritonei in MRI, because it is really very important and confusing, especially here in both the contrast. It is almost non-enhancing, but in some parties you feel like, what is this? Is this mental caking? What is this? Okay, so you feel like this may be some carcinomatosa of the peritoneum like this, but finally there are no enhancement. This is the bowel, all of this, and all the rest of the lesion is pseudomyxoma protonei expanding and distending the abdomen. Thank you so much for all of you.
Thank you so
Let's
much. What
meet
was the
in.
case? What was the cause in this patient?
Not mentioned in this case, but at least the most important is that you mention all the possibilities and that you pick up this is pseudomyxoma protonei in the MRI. Why? Because this in T2 looks like soft tissue, maybe, okay, confusing with soft tissue or peritoneal deposit or mesothelioma, all of this. But the key here is this one, post contrast. Almost no here, no contrast uptake, all of this. So it is very important to be aware of pseudomyxoma protonei in MRI. There are many questions. Dilatation, degenerative trauma. Okay, thank you so much for all of you. Thank
Thank
you.
you.